Hi there everyone, my name is Victor, I'm an ENT surgeon, and I want to tell you about epiglottic trapdoor phenomenon. It's a part of your airway that blocks off when you're trying to breathe, and I'll try and explain why this is important. So to give you a bit of anatomy to begin with, let's say this is your teeth, your tongue comes down like that, and then your voice box is down here. Your voice box is down here somewhere, and there's a long tube, the windpipe or the trachea that goes down here, and it goes into your lungs like that, left and right. So this windpipe comes up, and at the top of the windpipe, there is your larynx. And in your larynx, so this is the windpipe coming up, in your larynx, there is this opening and closing of your vocal cords. These are your vocal cords, open and close like that. Now, if this is sitting here, and your tongue is coming out like this, so your teeth are there, tongue like this, and these vocal cords are here, everything you eat and drink would just pour down into your lungs if you didn't have something to stop it. And the thing that stops it is a thing called the epiglottis, which is like a big barrier or shield or something standing just there. So when food and stuff comes down the tongue, it hits this and then goes around the outside. So it doesn't just pour into your lungs, it goes around the vocal cords just there. This is great. It's meant to stand up proud. Sometimes you can see it in very young children. If you look into their throat like this, you can see it standing up like this. It's made out of cartilage like this. And the great thing about it works really well. It's amazing how we can eat and breathe and drink water and it doesn't seem to get mixed up. It does sometimes, obviously, if you're laughing or something like that at the same time as eating or something. But it works 99.999% of the time in most people. Sometimes it doesn't stand up proud like this. Sometimes it can flat back. So if this is your little vocal cords here, or this is your airway here, let's do it the other way around. If this is your tongue coming down like this, and what happens is sometimes when you're sleeping particularly, you're falling off to sleep, particularly with your tongue falling back, everything can just flop down and block your breathing. It's a bit floppy. You sometimes see it in children. There's a thing in very young children called laryngomalacia, where this keeps collapsing in and blocking that child's breathing. So they're fine most of the time, but when they start crying, when they get upset, irritable, things like that, they start sort of not wheezing, they sound like they're sort of not, it's called stridor, like this sort of noise. I'm not sure this microphone can pick it up. It tends to get rid of all those extra noises I put into it. But they look like they're really trying hard, particularly when they're crying. And when they calm down, it seems to settle down again. And so that blockage can happen in children, but can also happen in adults. And you think, well, it counts for like 1 to 3% of people. Is it such a big deal? Well, for those 1 to 3% of people, yes, because, for example, the most common treatment for obstructive sleep apnea, this is when you're snoring so loudly that your airway gets sort of blocked off, you can't breathe, you go slightly blue, you have to take a breath to wake up again. Sometimes it's because, in part typically, that the epiglottis is coming down blocking your breathing. And the first line treatment for snoring and obstructive sleep apnea is a CPAP machine, a mask that goes in your face and pumps air into your lungs. That sounds like a great idea. It blows everything apart so you can breathe down the middle. But sometimes it forces this epiglottis to close down because the wind pressure is just doing that to you. So some people, when they're first put on CPAP, particularly when they're just lying down, the CPAP forces this thing shut and you feel like you're choking, you have to pull it straight off again. And when you do a drug-induced sleep endoscopy, that's when you watch people sleep at night, well, not at night, you give them a little sedation, so you see them snoring away in front of you in the hospital, you can look down there and go, that's the reason why you have obstructive sleep apnea. We know how bad you are, but this is the reason why you have obstructive sleep apnea. It's your epiglottis or your tongue falling back or your tonsils or your lateral wall or your arytenoids, whatever. We now know what your problem is, and here are the ways we can fix it. So when you do a drug-induced sleep endoscopy for people with a floppy epiglottis, you see it just flopping in like this and blocking their breathing. I'll try and show a video of it here. And there are lots of ways of fixing the epiglottis. You can say, well, why don't we just chop the head off it? So it does this, but you can still get air around the outside of it. I'm ever so slightly scared of that. I mean, lots of people do that. But I'm scared of it, you losing the protective effect of your epiglottis. So your tongue coming down like this, it may water may pour over the top of that and go into your lungs. Now, the people who do this seem to have very good results. There's a chap in Turkey who does an amazing operation. He stops it from, he removes the head of the epiglottis so it doesn't keep blocking off your breathing. I'm a bit scared of that. And so what I tend to do is try and pull this thing back so it physically can't do that. And there are basically 3 ligaments that hold the epiglottis in place. So if it's like this, there's a little ligament going here towards the tongue. That's like that. Maybe that's a bad angle. So if this is the tongue like this and the epiglottis there, there's a little ligament just here. It's not a very good tether between the two. But what you can, because it's quite stretchy, you can shorten this and stop it from doing that altogether. It works really well, and the risks are really, really low. And what I'll do is I'll show you in this video now. You can see that the tongue is just over here, and the epiglottis is just this area here. And what you'll see is that there's a little ligament in between the two, and I'm looking at it and being very careful to get exactly the right spot. And what I do is I put my probe, the Ceylon radiofrequency ablation, which if you watch this channel, you know I love. I put it in near the tongue because it's much safer to go near the tongue rather than the epiglottis. So I put it near the tongue, and then when I turn on the radiofrequency ablation, it naturally contracts this ligament. So it pulls the epiglottic forward. You might be able to see that now, and you can see it comes right up, and now it physically can't fall back again. Now, I like this technique because there's minimal pain with it, and if it doesn't go very well, or if for whatever reason someone out there, when I do this procedure, if they ever get this problem where when they drink something, it all goes down the wrong way, you can just snip that area, just release it again. Luckily, I haven't had anyone yet, and I just reduce it by about 50% because I'm so scared of causing a permanent problem. You can always come back and do some more, but doing too much is always a scary thing for surgeons. So I just thought I'd tell you that really simple thing that you can do to shrink down that ligament and pull the thing forward. There are other types of ligaments that go onto the side of the epiglottis. So sometimes the epiglottis doesn't just do this and block off your breathing. It sort of does that. It folds in on itself. I think someone called it an open book deformity or open book collapse. I think I heard that in India. I thought it was a really nice way of explaining it. It sort of does this. So I hope that helps. I know it's a little thing, epiglottic trapdoor, 1 or 3% of the population, but I thought it was interesting. Do take care. Thanks a lot. Oh, and thank you also to the chap who let me use his video. He knows who he is. Really, really nice, pleasant, polite chap. I can't look for a nicer person to help out with his snoring and obstructive sleep apnea. So thank you again for that as well. Do take care. Bye-bye.